Good afternoon, everyone. First of all, I am thankful to VKN Virtual Knowledge Network of Nimhans for giving me this opportunity. It's a very nice initiative that we are able to interact with people across the country. At the outset, what I would say that when I'm presenting, I have tried to make the slides as less complicated as possible, so that it's not very technical, and we discuss it. So please feel free to interrupt me at any point of time and ask questions, give your feedbacks and suggestions and your inputs, so that how you are working in your clinical practice. That would be quite interesting to discuss. So just some basic facts. As you know, every 10th year there is something called Global Burden of Diseases study, which is carried out in Naga. The GBD study, which is carried out every 10th year, the recent one which got completed in 2010, it puts schizophrenia as one of the most disabling illnesses, with very high years living with disability. The indirect cost of schizophrenia in terms of lost productivity is higher. It could be up to 7 times or more than that, than the direct cost. That is the cost that the patient or the family members spend on medication and other things. Is much lesser than the loss that they have in terms of job loss and other things. And the interesting thing is that the patients with active treatment, the symptom resolution, as we know that of late there is quite significant improvement in terms of antipsychotic treatment. So symptom resolution has started taking place quite substantially, but does it translate to functionality? If you see the outcome studies, it primarily shows that the patients, when they are symptomatic, they are symptomatic and dysfunctional, and after the treatment they become asymptomatic but remain dysfunctional. So ultimately, it does not translate actually to the outcome of the patient. And this is interesting and unfortunate, is that majority of schizophrenia patients never have independent living. They remain to seek support. They have to be supported by someone. Some more startling facts. Cognitive impairments are among the most important determinants of disability in schizophrenia. In fact, there is one study in which it was found that both positive and negative symptoms, as far as functional outcomes are concerned, and the disability weight is concerned, the most important component remains cognitive impairment. This is an interesting study done by Harvey et al. And I think this kind of studies has been done by others also. For example, there are people for example, Susan McGurk and all, where it has been found that cognitive deficits are better able to explain the functional impairments, such as poor work performance, than the positive or negative symptoms. And this is what this study I was talking about, that better cognitive functioning predicts better work outcome. This is again a very interesting study. I've given references of all these studies in the last slide, so one can actually look into these studies. The other thing is that cognitive impairments are widespread. If you see classic schizophrenia literature, which started coming in late 1980s, most of the studies show that cognitive impairments are quite widespread. It encompasses both primary cognitive functions, or basic cognitive functions, and the higher order cognitive functions. So it's quite widespread, and it is not directly correlated with chronicity of illness. So It is seen in all stages of illness, though with chronicity, of course, it increases. With institutionalization and other things, it increases. But then cognitive impairment is seen at all these stages of illness, and it's quite widespread. This is a very interesting study done by Susan McGurk and her colleagues, which has come in American Journal of Psychiatry. It shows that as far as the outcome in terms of real world functioning of the patients are concerned, when the rehabilitative interventions are substantiated or supported by cognitive remediation, then the changes are quite substantial as compared to doing only rehabilitation work, which does not incorporate cognitive rehabilitation. So you can see the two graphs, and it shows so clearly that if cognitive remediation is added to basic rehabilitation work, then the outcome is very good. So as I said, the deficits are widespread, and as we know that Kreplin's understanding of schizophrenia was very much supportive of the cognitive deficits that patients have. All the cognitive deficits have direct bearing on the everyday functioning. So the impairments that they have, and that gets translated to the everyday functioning impairments that we observe in the patients. And outcome improves if patients are remediated. I'll explain these last 2 points in detail in the next 2 slides. As far as impairments and their effects are concerned, patients invariably, whichever stage you take, do the assessment, the performance remains 1.5 to 2 SDs below than the healthy controls. And very interestingly, in fact, within comparison, if you do, for example, the patients who the performance of the patients at the premorbid level, if you have the data, most of the times we do not have neuropsychological data at premorbid level. But then for some of the patients, if one has, then within that also there is deterioration of around 1.5 ST. These deficits or impairments are not only substantiated by neuropsychological assessments. All the neurophysiological and imaging studies have shown that the patients have substantial deficits. For example, now there are fMRI studies, there are ERP event-related potential EEG studies, which have shown that the kind of cognitive assessment impairment, the cognitive impairments which are observed on neuropsychological test, they are seen on the other neurophysiological parameters also. With chronicity, deterioration increases, of course, but below average performance is seen in all the stages of illness. And even there is indication that premorbid manifestation of cognitive impairment can also be there. Now, so far as the domains of impairment is concerned, as I said that it encompasses basically all the cognitive domains. As you know, there is something called matrix. It includes 7 domains. I have added another domain for the reason that of late there are various findings that prospective memory impairments are there. So apart from that, this is mostly matrix domain. So patients will have difficulty in attention and concentration, in the speed of processing, in immediate memory, in working memory, both verbal and visual, long-term verbal and visual memory, and prospective memory, executive functions, planning, problem solving, decision making, and social cognition, which I'll explain again how social cognition actually corresponds with the neuropsychological impairments that the patients have. I think all these domains are self-explanatory, or I need to explain these domains? Do I need to explain these domains?
You won't have to do.
Okay. No questions coming.
Yes.
Now, how these domains translate into the deficits that you observe in everyday functioning. For example, people who have problem in sustained attention, they will have problem focusing attention on a task. When you talk to the person, when you discuss anything during therapy, it becomes quite difficult for them to be in the therapy, in the sense that they are not able to concentrate. As you know, of late there are various therapies which are coming, which are quite effective in schizophrenia. But for example, you have now CBT psychosis, you have integrated psychotherapies, which involves discussion with the patients, apart from all the neurocognitive domains and all. And it becomes quite difficult. People who are not able to sustain their attention, even if they become little motivated to participate in therapy, it becomes quite difficult to sustain them in therapy because of the attentional dissolution. Working memory, as you know, it creates problem in multitasking. So, and when you go for job or anything, most of the time the job will require some kind of multitasking. So people will have difficulty in that. Immediate memory, again, immediate interruption in meaningful communication, because they are not able to track what they are speaking. Sometimes it reflects as thought disturbances. So immediate memory impairments are important. Then verbal and visual memory impairment, which reflects in difficulty in keeping the information gathered during the therapy. Rehabilitation sessions, forgetfulness, which is again a very common complaint. If you see these patients when you do therapy, they are again quite forgetful of what we discussed, and sometimes we feel as if they are demotivated, but the reason could be neuropsychological, that they are not able to hold the information that we have discussed with them. Prospective memory, I'll just explain it a little bit because this is a relatively new term. Prospective memory is, when we talk about memory, we talk in terms of retrospective memory. For example, we learned something in past and then we recall it in present. So that becomes retrospective memory. But in our day-to-day life, there are many things which actually we do in context of future. For example, taking medication tonight at 7 p.m. So you form an intention now. For example, your doctor has prescribed, or the doctor has prescribed the medicine which is supposed to be taken at 7 p.m. The intention is made now when the person meets with the doctor and buys the medication. He makes an intention that he has to take this medication at 7 p.m. But at 7 p.m., so this becomes a prospective activity. At 7 p.m., there is no reminder as such. It has to come in his mind on its own. And due to prospective memory failure, it is very much possible that the person fails to remember that he has to take medication. Or for example, having an appointment with a therapist. It's very much possible that he had formed an intention, he was motivated to meet the therapist, but then it's just a prospective memory failure that he could not execute the intention at the right juncture. So prospective memory failure, this is why I said that I have included prospective memory also. This is very pertinent as far as day-to-day activities are concerned. Then executive functions. So the person can have difficulties in problem solving, and it can be seen in daily life. It may not be very complex problem solving. For example, if simply a person has to drive his pickup truck, or he has to go to a departmental store, it requires certain amount of planning, problem solving, and certain decision making, which if the executive function supports are not there, the person won't be able to do it properly. And then finally, social cognition, which is again seen quite of late. There are findings that social cognition is substantially compromised in case of schizophrenia. So that involves social reciprocity, emotional reciprocity, and other things, and it again translates directly in social relationships. For example, people are having difficulty in reciprocating emotions or understanding the intentions behind emotions. Their social interactions will be quite superficial. So again, social cognition deficits reflect in the impairments that they have in life. Now, what is cognitive remediation? Again, I have tried to. There are quite a few definitions. I thought that I should not be unnecessarily putting too many jargons about definitions. It's simply a behavioral therapeutic method which tries to improve cognitive function through training. And various meta-analytic studies have come. Two meta-analytic studies are very important, and they have actually given quite a bit of insight into the effectiveness of cognitive remediation. One by Susan McGurk in 2007 and the other one by T. Wykes in 2011. Both the studies show that cognitive remediations for individuals with schizophrenia is effective. There can be many mediator and moderator variables, but in general, it is effective. Domain-wise, there can be certain differences, and based on patient characteristic and many other variables, the effectiveness may vary. But then, overall, it is effective, and it should be provided to all the patients at all the stages, is something that has come out from most of these comprehensive meta-analysis. Now, this is something. This slide is quite. It looks loaded slide. Quite a bit of information is there. But I will really request those who are working in the area of cognitive remediation or those who intend to work in this area, please ask questions, because I assume that there would be questions in this slide, and there would be, you will be able to relate with some of the works that you are doing. So please ask questions and give your inputs when you are listening to this. There are various approaches to cognitive remediation in schizophrenia, and these are not separate. Perhaps in most of the cognitive remediation practices that we do, we use set of these things. I will try to explain all these things, and what I will suggest, I have not given reference to all these things, but in the last slide I have given references which which will be actually giving you further details if you read those papers about all these things. So first of all, there are two primary approaches to cognitive remediation. One is called restorative, and the other one is compensatory. Now, restorative is where you assess the person and you know that there are cognitive deficits in certain areas. So, for example, you understand that there is memory impairment, you understand that there is attentional impairment or executive function impairment. And then what you have drill and practice method where you have certain tasks and you make the person practice that so that he gets the area where there is deficit that gets restored, maybe completely, maybe partially or whatever. But then your target is primarily to restore that function as far as possible. The compensatory approach is where you don't try to restore the function, rather you try to compensate it with the other intact cognitive functions, or you try to develop certain strategies by which he is able to execute certain functions which have got compromised because of the cognitive impairment in a given domain. So, for example, a person who has memory impairment, he can be taught to use diaries. So he may not be, practicing memory methods. He may not be doing drill and practice on memory tasks. But then, by using diaries and reminders, he is able to execute many of the things which he used to forget because of the memory impairments. Even there can be a coach who helps him to do certain activities which gradually gets implicitly incorporated into his behavioral repertoire, and then he is able to do the things. Now, can anyone tell me which one you will prefer when you have to remediate someone? Would you like to go for restorative approach or compensatory approach?
Compensatory approach, so that we can have a baseline to start with and motivate them further.
So, and why won't you like to do restorative approach?
That we can plan a little later. Started with this restorative one, the person's motivation and even family members' motivation to come for further session becomes less. So start with something like, maintaining a diary or getting into that, so that they take the first step,
Okay.
and then they start coming back and the person gets motivated. Even family feels okay, he's somehow managed to function at least instead of non-functioning, and get the confidence that he may function better also. And probably at a later stage, when the patient continues with the therapy, we can go for a restorative one.
That's nice. Yeah. There's a nice suggestion that you start with compensatory approach, so that family members are happy that something is happening and the person is getting is able to do certain things, and then gradually you go to restorative approach. And it's really interesting because I have never, I'm very honestly I'm telling you, I have never seen a mix of compensatory and restorative approach. I have seen that mostly either you go for restorative approach or compensatory approach, or you go for compensatory approach many a times out of compulsion. For example, very low functioning patients where you are not able to make him do certain things, or his abilities are so less that you are not able to go beyond certain things. For example, you are not able to go beyond attentional tasks. Then people are forced to go to compensatory approach. I think this is a very nice idea that you start with compensatory.
Actually, I start with the compensatory, thinking that later stage I will go for a restorative. Nearly about 80% of the patients don't go beyond that because they are happy with that itself. They don't come for further session. There are few who come and who go for a restorative thing. Though I plan at the beginning itself, it is always compensatory and then only restorative. It is always a combined one. Depending on whatever is the function, even if the lowest function, even if it is highest function, I go for a compensatory one.
I don't know the empirical finding, but it appeals me the way you are telling. What I assume that for most of the patient, if we in the beginning itself and when they start becoming motivated because they are getting benefits, if we inculcate this idea that to regaining that capacity is also important, because we know that plasticity is possible. And if you go by compensatory approach, actually you are compromising with neuroplasticity. Whereas if you are going with the restorative approach, you are trying to start the plasticity process. So I assume that if we do both, and as you are telling, it would be very good. Thank you, ma'am. So the other one is top-down versus bottom process. Mostly again in studies, the bottom-up process is used, where you start with very basic cognitive functions. The assumption is that if you don't intervene or if you don't remediate in that domain, you cannot. How much time?
20 minutes.
20 minutes.
20 minutes. 20 minutes are over. So you can
20 more minutes. So bottom-up process tells that you first of all intervene or remediate the basic processes. So, for example, attention, speed of processing, and once the person has that, then you can build upon that. So you can go to executive functions and complex memory functions and all. There are people who argue that you do not need to go by this method, and you can actually start comprehensive remediation involving even executive functions. And they have got success. I won't say that they have not got success. But mostly the process is that you start with basic cognitive. For example, I am running a project and I have we are remediating patients. We are having this bottom-up approach where we are primarily for initial couple of weeks, we focus upon basic processes, and then we go to that, and we find quite a lot of benefit out of that. People start becoming more cooperative when they start attending to the task, and when we increase the complexity of task, attentional task, which somehow starts corresponding with working memory and all also, gradually they start becoming more amenable for executive functional tasks. So in my experience, of course, bottom-up approach is good, but then there are studies on top-down process. The next one is drill and practice versus practice plus strategy. Drill and practice is, as the name implies very clearly, is that where you make the person, you have certain number of tasks, and then you know the domain, and you address that domain by having those tasks, and you make the person practice those tasks. It can have the criteria of errorless learning. So what you can do is you have a task, and then you tell the person, or you monitor the person that on a given task, the level of the complexity that you are introducing, let the person reach to errorless learning, which is 100% output. And then when he has accomplished it, then you go to the next level. The problem is that if you keep errorless learning, then many a times, because of many other issues that creeps in this disorder, some patients may not go beyond certain level after a very, very long time, and then if you keep on giving the same task, the person becomes demotivated. So perhaps if the person attains certain level, trying or introducing new task is also not a bad idea. The other one is practice plus strategy. Practice plus strategy has, if you go by literature, it has perhaps two meanings and two levels. One is you coach the person to do a task. So you make the person practice something, and you also help him. For example, when you are introducing executive function task, you also put certain strategies, make him understand that, and let him practice that. That helps him. But it has further on, perhaps more acceptable and more widely used connotation is that you have certain targets, and then you use those targets while you are making the person practice that. For example, if you have a target to make the person work in a shop, you use the practices, or you use the task in that manner, that finally, and you use certain strategies to reach to that level. Errorless learning and mastery I explained. Then you have domain focused versus comprehensive approach, where this is again, sometimes we assume, and we, as literature says, that schizophrenia patients have widespread cognitive deficits. So you have a package, and you simply apply that package to schizophrenia patients, irrespective of the kind of cognitive deficits they might have. Whereas sometimes it happens, if you do the proper assessment, you will find that person may not have deficit in certain areas very much. So you do a domain focused work. Another one is quite important, is simply practice task or contextualized and personalized task. So either you have tasks, for example, you have certain tasks, say list learning or number cancellation or something for attention, and you make the person practice that, and you introduce different varieties so he remains interested, and you make the person practice. The idea is that will lead to neural activations, that will lead to plasticity, and it will have its own effect upon the function. Whereas contextualized and personalized task says that you make the person do it in a context, and it can be very personalized. For example, if there is a typist and he is not able to do something, then and you are trying to intervene the attentional impairment, then what you can do is you have the construct, and you can use the construct into his context. For example, if you tell the typist to take dictation when there are other distractions, so he has to pay attention to certain tasks, and he has to take dictation, and he has to type that, which is directly personalized to him, and it is in a given context that he is doing. Then you have paper pencil versus computerized task. So the person can practice on computers, and so if you go by studies now or the packages that we have, mostly it is computerized. It is easy to monitor. It is easy to and it keeps patients quite engaged also. The problem, at least in India, which we face, is that patients are not very computer savvy. They may not have access to computers. And that becomes a major hurdle for us to work. So paper and pencil task is good option, and we use paper and pencil task quite frequently. You can have individual retraining methods, or you can have group training methods. Many of the comprehensive remediation packages, they use group training. They form groups in a manner that this group becomes socially active groups, and that also helps into introducing the social cognition remediation part. The targets can be proximal or distal. Medalia's article is quite clear about it and very nicely written. You can have a very proximal target. For example, you remediate attention and then you do an attentional assessment, and you find that the person has improvement in attention. So you say that yes, there is improvement. Or there can be a very distal outcome. For example, you do remediation and you have the distal outcome of that the person gets a job. Or you can have an in-between thing that the person starts searching for something and starts paying attention to given task. So it depends whether you keep a very proximal target, or you keep a very distal target, or you keep target in between very proximal and very distal targets. Inclusion of metacognition and social cognition strategies. This is very important, and most of the comprehensive packages that are coming now, for example, CET, the cognitive enhancement therapy and all, they have started including the metacognition and social cognition part, because that helps in remediating into the deficits that they have in these domains. Okay, next slide, I'll explain what strategies can be used. Home-based versus clinic-based. If you read literature as such, most of them are clinic-based. But home-based, at least we have tried here, we are trying. There is one publication by Shantala Hegde, and we have found that home-based remediation is effective. In one of my projects that I am running, the preliminary data that we have interpreted, we have found that home-based remediation is as effective as clinic-based. There are certain methods that Dr. Manila will be talking about. And advantage for us, at least in Indian context, since I am presenting to the audience here in this country, it actually solves many of our problems of calling them very frequently in the clinic. Money and resources and many other issues are solved if we are able to work on home-based cognitive remediation. The last one is neurocognition plus social cognition, is same which I explained in the previous point, inclusion of social cognition strategies. Any question about this part of this slide? Any component? Because as I said earlier that any cognitive remediation practice will include a set of this. It's not that each are one separate cognitive strategy, or all the methods are clear. Okay. Manila, would you like to take it?
So now we probably discuss some of the domains and the various tasks that are frequently used on each of the domains that are worked on cognitive remediation. Right. I would invite the audience to probably tell us what are the commonly used tasks, perhaps in the domains of sustained attention or any of the domains that you're seeing in front of you.
For example, when you work with your patient, what task do you use for sustaining attention?
Grain sorting and rangoli.
Okay. So do you go by graded method? You increase the complexity of that?
Mine is mostly as an outpatient, and it is a home-based one. So the gradation is done by the family member or by the person himself, not by me.
How he decides to increase the
they themselves come out with more grains and 3-colored grains, and then they assess the time taken for that. Mostly the person himself does the assessment. Next time he says, okay, I will increase. on their own. I don't put it. I just only give the way, and it's a home-based one, and they themselves come with a more complex and grading.
And if you have to contextualize, as I was discussing in the previous slide, if you have to do it in context of the given patient, or if you have to personalize it according to his individual requirements, can you give any example?
It all, again, it is personalized. Most of the housewives who come and most of the other people who are, who cannot go beyond, trying to get married or being useful in the family by cooking or something, they don't go beyond the grain sorting or rangoli. But there are some men who go for alphabet crossing, and sometimes they themselves make it a more graded, like 2 alphabets crossing and 2 columns in a newspaper crossing, like that. They go on increasing at their own comfort level.
Okay. This is again interesting when you are using the term their own comfort level. Actually, the near which is has been given by Medallia. It tells that the person can actually decide his task according to his comfort level. The only thing is that tasks are pre-decided, and he has to choose when he comes out. So this is a nice idea. It motivates the person. It sustains the person's motivation. It's a nice idea. The only thing is that I assume that if you decides the complexity from at your level, you will be able to increase it according to in a more graded manner. Sometimes patients very enthusiastically or not understanding in their naivety, they can have their own gradations quite difficult. Okay. So for working memory, what common tasks that you can use and what can be a contextualized or personalized task? Go ahead.
I have just started so that others will join, That's why let others come out.
Okay. Then go ahead. Okay, so we have certain results.
So we have a couple of tasks here that we've mentioned. So for example, for sustained attention, one of the commonly used tasks for sustained attention is the coloring task, where initially each of these tasks increase in complexity as explained earlier. So initially it would start probably with a square where they have to pay attention to the amount they press on the paper or not going beyond the lines. And as the complexity increases, probably more complex shapes would be what they have to color within. Letter cancellation also, as mentioned earlier, is one of the frequently used exercises for improving sustained attention. In the earlier levels of letter cancellation, they would be required to cancel 1 or 2 letters only in a series of letters that are presented. In a higher level, the letter cancellation may involve tasks such as cancelling a letter which is, for example, not preceded by a particular other letter. For example, cancelling the letter X, which is not preceded by Y. So this would often almost become like a working memory task. The bead sorting task has been explained. Working memory, we often use the N-back test. This is a test where, again, a series of sounds are made in the verbal working memory. Verbal N-back test, where a series of sounds are made and they have to tap on the table whenever every alternate time there is a similar sound that is made. For verbal and visual memory, as well as prospective memory tasks, for verbal and visual memory, we often use route learning, where a route is taught to the client for visual memory, and later on, the alphabets placed on the sheet which indicate the route to a particular destination are removed, and the client is to remember how to get from destination A to, for example, destination C. List learning is very similar to auditory verbal learning task, where a series of lists are given and multiple trials are given where they have to remember the words that are being given to them. For prospective memory, something we frequently use is use of diaries and reminders for tasks that they might have to do in the near future. For planning, mazes is something that we often use for assessment as well as for remediation, where a person is to reach from point A to point B. But this involves a significant amount of planning because you are not allowed to lift the pencil off of the paper. So you have to plan up ahead of time what routes you would like to take. Metacognition tasks include various tasks that focus on theory of mind. These are some of the tasks that we frequently use for remediation on some of the domains.
Yeah, and for social cognition, I think I just forgot to add certain things. These are the cognitive errors that you find in psychosis. So when you work on metacognition, as you know, perhaps you might have heard there is a package called Metacognitive Therapy by Morris and Todd. It has very nice, steps, and there are 8 modules which can be practiced. So that has though it is primarily focused upon delusions, but then there are things which can help in improving metacognition, which is related to social cognition. Of course, also there can be tasks, or there can be things which improve social reciprocity. So you make groups, make person understand the social interactions, the social issues, have inferences about emotions. These things can help in improvement of social cognition. Now, on the right side, we have written the very personalized and contextualized what can be. Common, what I am telling is, common is not commonly used, but common in the sense that this is something which will be used for any patient who comes as part of the retraining method. Whereas when it is personalized, there are certain examples that we have given. For example, in the previous part, I just gave the example that for a typist, sustaining attention to a dictation in the presence of other distractors is to improve attention. For a student, solving some mathematics and other things while holding information will actually support working memory. To-do list, if the person remembers, it will help him in his day-to-day life, and of course it will help him improving memory. Problem solving in a simulated real-life conditions. For example, asking the person that this is a departmental store and you have to you have 5,000 rupees and you have to buy certain things. So the person has to plan and has to take decision. Otherwise, he will spend money without understanding the whole expenses that he has. So all these things help. I will also suggest all of you to read this paper by Shantala Hegde. It has come in Indian Journal of Psychiatry. I have given the reference in these slides. In 2012, it nicely describes some of the drill and practice tasks, not the contextualized tasks, but drill and practice is nicely explains this. Now the question is that what should be the duration of all these things? So it varies. There is no, in no meta-analytic studies it is written which is the exact duration where the cognitive remediation is most effective. In fact, people have come out with that very short duration cognitive remediation is also effective as long duration. But then most of the studies prescribe that it should be somewhere around 3 to 6 months, which is around 12 weeks to begin with. And people have done 10 hours a week, people have done 6 hours a week, but then 3 to 4 hours a week, which is normally used and which is doable. If you make it too much, the person won't do. But 3 to 4 hours a week, the person will be able to sustain his motivation and interest in that. These are 2 very commonly used comprehensive programs. One is neuropsychological educational approach to rehabilitation by Metalia and Philip. It has wide variety of tasks and that are quite intrinsically motivating. And then cognitive enhancement therapy, which is again very nicely designed task, which has a component of neurocognition, which is a component of social cognition, and then patients themselves interact, and the group interactions help in social cognition improvement. This is again a very effective therapeutic method, and very nice paper has come in 2010, I suppose, in Archives of General Psychiatry. No, it is JAMA psychiatry. JAMA psychiatry, which they have found that this therapy has led to gray matter changes in the brain, which they have done by 3 MRIs, I think, for each patient. So that is something very substantial, which shows that there can be actually neuronal volume increase in after this therapy. Now, how to do cognitive remediation in clinical practice, I will be just briefly explaining. Have a neuropsychological assessment, have a social cognition assessment, and other quality of life and other assessments. See evaluations of resources and feasibility. For example, if you monitor, of course, it would be very good, but then how many patients you can monitor? So the feasibility that if we do home-based cognitive remediation, and if we have a caretaker who can actually take care of the things, if we train them properly, as Manila will be explaining when she is talking about her case, it helps. So have evaluation of resources and feasibility, see whether you can go for home-based or clinic-based, see whether you want to go for restorative versus or compensatory practice, and then you do a post-assessment, do a follow-up. This way you will be able to understand whether the change has occurred or not. Now, some of the factors that may affect response to cognitive remediation is, one is motivation. Motivation, now there are many papers that are coming out, is that motivation is one factor on which you have to work if you are working for cognitive remediation, because there are two reasons. One is that due to the nature of the illness, many patients have their own anhedonias and dissociations and all. So they may not be motivated for therapy, and then you won't be able to remediate. The other one is that when patients who are having a traumatic brain injury, many of them are very categorically able to understand that or perceive that this is what their functional level before the injury, and now this is what their functional level. So they strive to gain that thing. But in schizophrenia, it becomes very slowly. When does it actually start occurring? People don't know. We don't know when it starts occurring. So they are not very much motivated for those things. They are not able to understand and perceive those changes. So it has been found that motivation can be more so intrinsic motivation. Motivation not in terms of that you do and you get money, so that is why you are getting. Intrinsic motivation, when you start feeling that if I do this, I am going to get benefited in this manner. That is very important, and most of the therapies, most of the researchers in this area, they now suggest that we work on motivation very much if we are working on cognitive remediation, because it becomes a very important mediator variable, may not be moderator variable. Chronicity is important. As chronicity increases, the cognitive deficit may increase. But at the same time, it does not mean that people who are having first onset illness, they are not having cognitive deficits. This is what in the meta-analytic studies tell that it has to be done at each level and for all patients. Type and intensity of intervention. So this is what, whether you want to go for restorative, you want to go for compensatory, you want to go for home-based or clinic-based or computer-based or paper-pencil-based, they can have certain effects, differences. Though there are not very clear-cut findings that this is effective and this is not effective. Most of the studies, so whichever method they have used, they have found that there is very effectiveness. So I think maybe after some time there will be some studies, meta-analytic studies, which will show that in comparison to this, which is more effective. For example, of late there are findings that strategy approach is little better than drill and practice approach. So that way maybe in future findings will start coming. With or without rehabilitation program, as I explained in the previous slides, that if you have rehabilitation program which is with cognitive remediation, then the improvement is better. Premorbid level of function, people who are having better premorbid level of function, they respond better. But at the same time, those who are not having very good baseline this one, they also respond to treatment as per their this one. So if you compare their score from a pre-post, there would be change. They may not be in group, there may not be change. Level of impairment and function at the time of initiation of remediation, that is also important. So I end here, and then I request Manila